Good evening. Good evening. Tonight is going to be an amazing night. We have so many things going on. First things first, it's all about tools to prevent and manage diabetes, presented by University of Maryland Medical Center. I'm Persia Nicole, and I have some amazing experts with me, as you can see on the screen, to help us navigate this very important conversation for our community. First, I would like to introduce you to Dr. Davin Chow.
Hey, hi, how's everyone? My name is Dabin Chow. I'm a general internal medicine physician. I practice primary care. Been a member of the faculty of University of Maryland for 10 years now, and my location is right at University of Maryland Medical Center Midtown campus, and I'm privileged to work with some wonderful colleagues in the Division of Endocrinology to help manage patients with diabetes in our community.
Yep. Next, I want to introduce you to Dr. Kashif Munir. How are you?
Great, I'm doing great. Thanks for having me and all of us on. I'm Kashif Munir. I've been at the University of Maryland as faculty since 2011, and I'm currently the medical director of our Center for Diabetes and Endocrinology here. We moved to our new building, which is a brand new ambulatory care tower, and we have a beautiful space where we see patients with diabetes and other endocrine disorders, and we can see them, we can treat them, we can educate them, we can manage acute issues and also long-term care. So we have a lot of great things going on there, and hopefully we can discuss a lot of that tonight.
We're definitely going to get into all of that tonight. We have a very important conversation. Lastly, of our experts, Dr. Alexandra Morán. How are you?
Hi, fine, thank you. Thank you for having us. I am a physician. I graduated in Ecuador originally, and I've been coming back and forth to Maryland, so I'm not as seasoned as Dr. Chow and Dr. Munir. I actually started just about a year ago at the University of Maryland, and I am currently the director for the diabetes program.
Nice. So thank you so much for all of you. As we are having this conversation tonight, if you are on Facebook, wherever you're at, on YouTube, type in the chat and let us know if you have some questions, so we can make sure we get our experts to answer that tonight. First, I want to talk about this. Now, diabetes, of course, is a very common condition. A lot of us know about diabetes, that it affects millions of people each year. However, many people don't know that they even have it. Why is it, Dr. Munir, that you feel like people just don't know that they have diabetes?
Yeah, no, it's a great question, and like you said, maybe even up to a third of people who have diabetes don't know they have it, and a lot of times it's because the symptoms either are subtle, or people don't recognize it. So the common symptoms of diabetes, sometimes it could just be fatigue, or sometimes you might not have any symptoms if your blood sugars are not that elevated. But commonly, people will start to feel like they're getting thirsty a lot. They have to drink water all the time or drink something all the time. They're urinating a lot. They might have to get up at night to go to the bathroom several times, which is, might be a change for them. They might feel like some numbness or tingling in their hands or feet, or vision changes like blurry vision. So if you're having these types of symptoms, then definitely you should get checked out, especially if you have a family history of diabetes, which we'll dive into. But that would also increase your likelihood of developing it at some point.
Yeah, just one tip that I would probably give, and I'm pretty sure all the doctors here can agree to this, is to probably stay off of Google. Google will tell you the worst of the worst, right? For me, I'm definitely going to contact my doctor first and say, hey, here's my symptoms. Can I come see you? Instead of Google will tell you the worst. I see you, Dr. Alexa, smiling at the bottom. Do you agree?
Well, from my experience, from my friends at least, when they Google something, it's always they have cancer and they're going to die. So.
Okay. Yeah, Google definitely is like, today's your last day on earth, to just enjoy it, like, right? So I would definitely say make sure you get the proper help that you need. Dr. Chow, can you talk about this, explain the difference between pre-diabetes and diabetes, because there is a difference. Can you explain that?
Yeah, sure. So the symptoms that Dr. Munir just described, those are symptoms where the diabetes is well in place, and by the time the patient has symptoms, that you're unfortunately you may have experienced some potentially untoward effects of diabetes. You would love to catch it sooner than that. You would like to catch it before the patient develops symptoms. And so it's not like being pregnant. You're diabetic one day, you're not diabetic, and then the transition is a gradual one. So there's this stepwise progression from not being diabetic at all to being pre-diabetic, and then gradually you transition to being diabetic. Usually, if you're pre-diabetic, you don't have those symptoms that Dr. Munir described, but those patients need to be diagnosed, identified, and treatment can begin at that stage so that you prevent that patient from going on and developing the symptoms and potentially the side effects, adverse effects of having diabetes, as Dr. Munir described. So pre-diabetes, there's a criteria for it. I don't know if we want to get into all that, or is that?
I mean, listen, we have an hour, and I think that our listeners could definitely take this information and gain a whole lot from it. So, as much as you want to share.
Yeah. So I urge everyone to, even if you don't have those symptoms that Dr. Munir described, get yourself screened, get yourself tested, and it's possible that you may fall into this category of having pre-diabetes. Unfortunately, tens of millions of people in this country have pre-diabetes, and they don't know it, and they are on the pathway. They're on the track to developing diabetes down the line into the future. So the way that we check is to check a blood test, and the blood test one blood test could be your blood sugar. Another blood test is a special test where we can assess the average of your blood sugar over the past 3 months. It's a cool test, and it's just one blood test, and it can sort of average out all your sugar results over the past 3 months, and that will help us identify whether you fall into this category of pre-diabetes. It's nothing. The pre-diabetic needs attention, needs medical care, and we don't want them to advance and develop diabetes in their future.
Yeah, and so also when you talked about doing like the blood test, right? So like Dr. Moran, if somebody, like you said, is not like being pregnant, right? But if someone is pregnant, they're saying, hey, like I have diabetes, I'm so scared to pass this down to my child. Is it hereditary? Do they have to worry about diabetes being passed down to their child? Or if the mother or father had diabetes, is this something that they would have to worry about?
So yeah, there is definitely a genetic component to it. However, there's just a broad things that can put you at risk, right? One of them being overweight, one of them having that genetic component, if you have somebody in your family that had diabetes. Also, if you were diagnosed with diabetes throughout a pregnancy, that also puts it at a greater risk for later on. And then when you're talking about being overweight, everything that puts you in that spot also puts you in the same spot for diabetes, right? So if you don't work out, if you eat a lot of carbs, if you are sugar through the roof, so the way that you eat, the way that your daily activities really are going to have an impact and put you more at risk. So like Dr. Chow was saying, right, we want to catch those patients when they are pre-diabetic before they become diabetic. And like Dr. Munir was saying, all these signs and symptoms really are silent. You don't really know that you have it, or that you have reached that limit with your glucose. So you want to keep an eye on if you have those risks, if you're overweight, if you're sedentary, and if you have that genetic component in your family.
Now,
so
go ahead. I'm not familiar with this though. What is A1C and what number should we aim for?
So the A1C is what Dr. Chow was referring to. It's a glycosylated hemoglobin. Is a test that measures the for 3 months, and literally it's kind of like the way I explain it to patients. It's like a glazed donut. That's what it measures. It measures the glazing on the donut, right? The donut is the hemoglobin, and then the glaze is the sugar on your blood. So when we're talking about normal ranges is below 5.7. Pre-diabetes is 5.7 to 6.4, and over that is considered diabetes.
Thank you for that glazed donut analogy, because I think we all know what that is, right? So we can see, like, I'm visioning everything right now. Let's talk about this, Dr. Munir, because a lot of people, you hear them say, I have type 1 diabetes, I have type 2 diabetes. Can you break down the difference on what that is?
Yeah, so those are the two main types of diabetes that we've categorized it, for the past many years. They used to refer to these as juvenile onset diabetes and adult onset diabetes, but as we've learned that people who are older can get type 1 diabetes and people that are younger can get type 2 diabetes. So they've kind of reclassified these names. So type 2 diabetes is the more common form of diabetes. That's like 90 to 95% of people in the US. And with that disorder, you still make insulin, but your body isn't able to utilize it as well as it should. So what happens is you're making insulin, but your body's not using it, and so then your cells are not able to take up glucose, and this glucose or your sugar, it stays in the blood and elevates in the blood. And so over time, diabetes, whether type 1 or type 2, all that sugar in the blood can cause damage, mostly to blood vessels. That's the main downstream effects of diabetes and uncontrolled diabetes. Type 1 diabetes is usually in younger people, but again, it can happen in older people, and that's often related to what we call an autoimmune condition. So your immune system actually attacks the cells in the pancreas. They're called beta cells, and those are the cells that make insulin. So after this immune kind of attack on the pancreas is able to make less and less insulin, and eventually you need insulin. So with type 1, you actually need insulin as a treatment. That's the only treatment that we have right now. There's other things that can help insulin. There's a few things that are approved, but really insulin is the mainstay of treatment. With type 2, you can often treat either with lifestyle, so some people don't need any medication, but you can also use different medications that are pills or oral medications. And then there's insulin and other injectable medications as well. So with type 2, we have a whole lot of options in terms of what our treatment possibilities or potential treatments are.
And I want to remind you, as you are watching on whatever platform you're watching on, if you have any questions, just type it in the chat. We'll make sure we get it up on here. Tools to prevent and manage diabetes. We want to help you, our community, make sure we're living a healthier lifestyle and really get you before you get to that point. We talked about the pre-diabetes and diabetes. And of course, we'll recap some of this later on in the show if you missed any of the information. Now, Dr. Chow, are certain populations more prone to having diabetes or pre-diabetes?
Just to add on to what Dr. Munir was just saying, if you have pre-diabetes and then you go on to develop diabetes, the type that you're going to go on to develop is the type 2. Yeah. The pre-diabetic doesn't transition onto type 1 diabetes. And unfortunately, based on the risk factors that Dr. Morán described, we have a high prevalence of type 2 diabetes in the U.S. population, in here in Baltimore, and here in the Midtown area. There's a high prevalence of pre-diabetes and diabetes that we're challenged to manage, and most of those patients fall into the type 2 category. I hope, I wish that we could identify some of those folks early and identify them in the pre-diabetes stage before they advance into diabetes. But unfortunately, some of them we identify late, and they may have already developed some complications of diabetes. And I guess we'll touch upon that as we go on.
Yeah, I actually want to talk about the complications. Now we can kind of dive into that, like some of the risk factors associated with diabetes. So if you want to touch on that now, Dr. Chow, we can do that.
Sure. So, so unfortunately, diabetes affects all organs of the body because this is a problem. Diabetes is a disease of metabolism, and all body tissues, all body organs are involved in metabolism. But the symptoms that we are most troubling, most worrisome is one is the kidneys. The kidneys can suffer damage if the blood sugars are not well controlled. The eye can suffer damage, and patients can lose vision if the diabetes is not well controlled. And finally, the nerve endings can experience uh, uh, failure to work if the diabetes is not well controlled. So those, and all of those can end up with complications. Um, and it's a shame to see patients experience those complications, because diabetes is potentially a treatable disease if we can get the sugars under control.
Yeah, and I think that's probably one of the biggest factors too, is because I think after COVID, I had read something that a lot more people found that they had diabetes. I mean, people were in the home, they were just eating sweets. I mean, it was kind of nothing to do but to eat things that we weren't supposed to be eating. Did you find that more people had diabetes or developed diabetes after COVID? I don't, Dr. Moran, do you want to talk on that?
I don't know if necessarily it was after COVID or not. I think the
Maybe it was
prevalence was always been there.
right.
Maybe they just found out.
Right.
So I think that. But I did wanted to mention something when you asked Dr. Chow was what population really is more prevalent. I do want to emphasize, because it is prevalent here in Baltimore, is that Black and Brown communities are specifically more prone to have diabetes. It's a lot of factors, most of culturally, right? I can speak as a Latina, right? We eat horrible, delicious, but horrible. Most of our plate is considered carbs. And also a lot of social determinants of health, of where we grew up, how we grew up, if we have access to a park to go run, to have activity, if we have these, food deserts where we can't get healthy food. So all of those really play a role in what population is more at risk. And I want to mention is the after the elderly you are, the more likely your pancreas is kind of giving out and not producing as much insulin, as Dr. Munir was explaining.
Yeah. And Dr. Moran, also you talked about some things. I mean, of course, like the eating factor, right? But what other tools are there to help us prevent and manage diabetes? What else would you suggest?
So when we're talking about prevention, the program that we have at University of Maryland is called Diabetes Prevention Program, and it really emphasizes what the tools that you need really to not get to diabetes. One of them is learning how to eat and what to eat. So your diet is a big part of it. So just always making sure that you include those vegetables, that high content of fiber. And you can eat carbs. We're not saying that carbs is the enemy, but you need to know what kind of carbs and how much you're supposed to be eating, right? And a big piece of also is exercise, right? You want to make sure that that glucose, that sugar that you are consuming, gets metabolized, it doesn't stay in your blood. So how do we do that? Is by exercising. So if you exercise, you grab that sugar and it gets consumed and it doesn't stay in your blood, which is what we also want to prevent. So those are, again, are tools. A big thing is just the behavioral health. It's in your mind, right? So a lot of tools on how to deal with certain situations we teach you in the class. Like, we're not telling you that if you go to a birthday party to ever have cake, right? What we're telling you is what can you do in that situation? You know what? I'm going to have a lighter lunch, maybe a lighter dinner, or maybe I'm going to go walk after, right? And you can enjoy that piece of cake. So those are the things that we teach during the classes, those tools that you need to, how can you prevent it? How can you have a behavioral change overall that's going to get you to prevent diabetes? And then when we're talking about diabetes management, it's the diabetes self-management program, in which you have consult with a nutritionist, and then you have 9 other consults, and you have a group of people that are going through the same thing you are. So you just learn more about how the day-to-day of diabetes, right? About how to manage your insulin or your metformin, depending on what you're on. how many protein you're supposed to be eating before bed, so your glucose doesn't go all the way low. So there's a lot of nuances about managing diabetes that you learn, and you have a support group that can really, you can relate to that because they're living together, going through the same things.
Hey, Dr. Moran, I just heard something that you said that gives me a glimmer of hope. You said that it's okay to eat carbs. Can you say more about that? You said there is a carb that you can eat. I'm very anxious to hear what that is. I love to eat carbs. I feel guilty.
Well, I mean, there's actually been a lot of research done about just how you pair your carbs, but really you want carbs that are paired and that have more fiber. That's not going to do that spike, because that's one of the things that we want to do, right? If you eat fruit, if you eat a donut, your glucose is going to spike right away, and then you're going to come crashing down, right? You're going to feel lethargic, you're going to feel sleepy, you're going to feel with no energy, and you're going to be hungry again within 20 minutes, right? But if you have a carb that has more fiber, more complex carbs, you're not going to digest it as fast. It's the glucose spike is going to be like more flat and longer. So what does that do? It keeps you fuller for a longer period of time. So you're not crashing down after that sugar high, right? And you have energy longer, and you're full for a longer period of time. So you don't eat after 30 minutes, right? So that's mainly what we want to focus on, is just making sure that you get a lot of veggies, a lot of fiber, and that way you can have that treat of the carb.
So I can have Alfredo pasta with broccoli on it, because it got even down.
And salad.
And salad. There we go. We're all happy, right? Really quick, back to the programs. Is it only for adults, or is it for adults, and can children participate?
So the program is unfortunately only for adults, but we do, for the DSMT, they do have, if they have been diagnosed with diabetes, they do have that for kids.
Okay. Dr. Munir, what does it mean to have uncontrolled diabetes? Like, what symptoms or factors might require a trip to the ER?
Yeah, so uncontrolled, basically we set goals for our patients, and a lot of it surrounds that A1C test that we've talked about, or hemoglobin A1C, and so that it's really a great test for, again, long-term, kind of assessment of how sugars are. So before it was just we check the sugar here or there, and then you don't really get a full answer. And so what we found is that people who what we've done is we've kind of set goals for people based on what their complication risk is. So if somebody's younger and healthier, then we really want that A1C to be close to normal. That's our goal. If somebody's older and has a lot of complications, then we actually have a little bit looser target, because then those patients are at more risk of actually having low blood sugars sometimes. And so you have to be careful. And we haven't found there's a great benefit in keeping them really low. So we individualize that target. And the main goal for diabetes care, and why we like to be controlled and not uncontrolled, is to prevent complications. And so Dr. Chow is starting to mention some of these, but really diabetes affects blood vessels. So we kind of divide it up into, and it can affect almost any organ in the body. So there's a lot of complications that potentially can occur, but the good news is if you control things well, then you can actually minimize your risk for all of these. But the blood vessels, we kind of divide them into the main things. So there's small blood vessels. So those are the blood vessels that like go to the back of the eye, or to the kidney, or to the nerve endings. And so that, if we get those damages, and diabetes is like one of the leading causes of blindness in the working age population. It's the leading cause of needing dialysis and what we call end-stage kidney disease. It's one of the leading causes of amputation. So there's a lot of bad things that can happen if you're uncontrolled, quote unquote. And then the other problem is that it's one of the leading causes of heart disease. So it affects big blood vessels, like in the heart, the vessels that go up into the brain, and if they get affected, you can cause stroke. The vessels that supply blood to your legs, and so we call that PAD, or peripheral arterial disease, and that can increase your risk for potential amputation. So there's a lot of things that can occur if you're, quote unquote, uncontrolled. And so the higher that this A1C is, the more risk there are for these things. But diabetes is also a syndrome. We call it one of these metabolic syndromes. So things like blood pressure, cholesterol, those are also very important. So we want to, when we treat diabetes, we kind of treat the whole syndrome. We treat the blood sugar, but we're also very aggressive at managing the cholesterol, very aggressive at managing blood pressure. And the good news is in studies that if you do control all of these things, and treat all of these things, many patients will never have any of these complications. So we don't like to scare people in the sense that, oh my God, this is going to happen. But at the same time, it could happen if you don't control things well. But if you do control things well, you really can minimize your risk. So basically, with uncontrolled, this A1C technically use kind of a level of 7. And the reason again is after it goes above 7, you start to see the risk of like eye damage, kidney damage, so on, start to go up. And so if you keep it below that in general, that's better. But again, if you're 85 years old and you already have heart disease, then maybe our target's like less than 8. If you're 40 years old and you have complications, then maybe our target's in the low 6s. So again, we modify that based on the patient.
Okay. And Dr. Munir, I want to stay with you for a second, then I'm going to go over to you, Dr. Chow, because I want to talk about how your teams work together along with other specialists on University of Maryland Medical Center's Midtown and downtown campus. So let's talk about the collaborations that you have, Dr. Munir, first, and then we can go over to you, Dr. Chow.
Yeah, so we have, one of the beauties of this new tower is we have a lot of the specialists that deal with diabetes all under the same roof. So even within our diabetes center, we have some associated specialties. So we have podiatrists who come, and so those are the foot doctors that can look at people's feet, make sure that they're not having, ulcers or complications. They can help keep their feet in good shape to minimize that risk. And then we also have diabetes educators. So they do some of this, what we call this diabetes self-management training that Dr. Morán was talking about. So they give a lot of the education. They help people with a lot of the diabetes technologies that we have. So we have like things like glucose sensors now. So before where you're sticking your finger and getting a sugar maybe once or twice or 3 times a day, now we have technology that can measure your sugar every few minutes. And so you get more than 200, 250 readings a day or more. So you really know what's going on all day long, all night long. And so these educators can really help patients with that kind of technology and as well. And then we have psychological support and social support in our center. So we have social worker, we have a community health worker, we have a psychiatrist who comes there, and we also have a pediatric practice. So you're asking about kids, so we have a pediatric endocrinologists and then also pediatric educators. And then within the tower, because a lot of the complications affect so many organs, we have our primary care doc, so Dr. Chow is there. We have our cardiologist to help with heart disease. We have our gastroenterologists. So these are, they help us because a lot of people with diabetes are at risk for something called fatty liver disease. And that can actually cause liver complications and even cirrhosis down the line. We have our nephrologists, which are the kidney doctors, so they're right there. And then, we have a wound center. We have the eye doctors right below us. So we have kind of all these things that somebody with diabetes might need to use or should, engage with for screening and making sure they're monitoring for complications like, especially like the eye disease and the foot disease and so on. So it's really great because patients can come to one place and kind of go up and down the tower and see almost everything that they would potentially need to see.
Dr. Chow, do you want to add to that?
So let's suppose that that you're a new patient and you have diabetes, and you come to see me as your primary care doctor, and I'm glad to see you, and I will usually have them consult with the dietitian and the diabetes educator in the endocrine clinic. They know a heck of a lot more about counseling patients about diet and about managing diabetes than I do. And the patients love the interaction with them. And then, so the patient will follow with me every few months, and we'll keep track of them. But then, suppose the patient then has an uncontrolled diabetes that, despite my efforts, the sugar is not well controlled. Then I'll send them to an expert like Dr. Morán or Dr. Munir, and they would then have more tools at their disposal, more resources, and magically the patients come back to me, and all of a sudden their diabetes is much better. And this has happened quite a few times, and I'm always amazed and humbled whenever I send the patients to them, because struggle as I do, I can't seem to get that sugar under control, but they're able to do that. And then we sort of co-manage the patient together. They will see the endocrinologist every few months. They'll see me every few months, and I think it works. It works well. The endocrinologist will focus on diabetes-related issues, but I might focus on other things, like making sure that, in addition to their diabetes, that they get the vaccines that they're supposed to be getting. Make sure that we monitor any heart-related risk factors or heart-related issues, or other diseases that may be ongoing. So it's a team, and at different times, one member of the team takes more responsibility than the other for the care of the patient. But in the end, it's a team effort, and our goal is to just do right by the patient, and that's what we're here for.
I love that. And I love that you said also it's a team, because so many times you might have doctors in different sides of the fence. One's over here, one's all the way over here, and they don't work well with each other. They maybe don't have that contact, but you guys are in contact. You're working as a team, so that way it's the best interest for the patient. And I think that's the best part for me. Mm-hmm. So let's, I want to actually dive back into the prevention program as well. The diabetes prevention self-management program. Can we talk about, Dr. Morán, how you can sign up for either of the programs, and also do you have to be enrolled in either of the programs to see a diabetes specialist?
First, no, you don't have to be enrolled to see a specialist. You can just get the referral or just make the appointment to see the specialist. You can self enroll in our webpage. So we have umdiabetes.org. You can self-refer, or your primary care physician can refer you. And then you're going to get a call from my team regarding more details of how to enroll and how we can get you started for the next class available.
Okay. Dr. Munir, can we talk about if you're experiencing some of the symptoms we mentioned earlier, whether it's excessive thirst or blurred vision, what should your next steps be?
Yeah, I mean, the next step is really to get tested. I would go to your primary care doc if you have one, or or you can even visit like an urgent care. I think one of your previous questions said, when do you go to the emergency department? So, the good thing is that most of the time you can manage most of diabetes outpatient, meaning outside of the emergency room, outside of the hospital. And so that's really our focus. We don't want people to go to the hospital because you have to wait there a long time, and then usually what happens is they'll stabilize you, send you out, but you might not get a good long-term treatment plan. So we really want people to engage their primary care doc, their endocrinologist, or try to follow up with the diabetes center to help manage these things long term. If the time you would go to the emergency room is if you're feeling really sick, you have nausea, you're just feeling terribly, chest pain, things like that, then obviously you go to the emergency room because that's more urgent. But I think overall the good news is that you can really manage this outside the hospital, and we can help kind of give people, we can even see them every day if we have to really get them on track and get them on board and get them better.
Yeah, Dr. Chow, did you want to add to that?
No, this is I think we see, unfortunately, here a good number of patients who are hospitalized and they have diabetes that's not well controlled. That's that should not be the first place where the diabetes gets diagnosed. But the diabetes team also helps us out in the hospital. They will come do consults, help with advising what patients should be discharged on, and help arrange an appointment in the diabetes clinic so they can get good follow-up.
Yeah, and I'd like to add to that. I think what Dr. Chow said is really important. We want to catch these things before it gets out of control, right? And so if we can, if we can screen people, so who do we screen? So I think it's some of the things that you were getting at, like who are the high risk people? So like Dr. Moran said, it's an age-related disorder. So as you get older, there's a higher risk. If you have a family history, if you have, certain racial and ethnic groups, like she mentioned, so all of those things are important. And so, seeking regular kind of checkups, preventative care. So maybe you can catch it when it's pre-diabetes and prevent it from ever getting to actual diabetes, and that would be, the best.
Dr. Moran, I know you talked about. Oh, go ahead. You want to add to that?
Yeah, to what Dr. Munir is saying. Just so people know, we do screenings in the community, but also in InCheck at the basement. They do screenings for A1C, and people can just go from 9 to 5 and get screened. Again, I think we can all agree here, the most important thing and the message that we want to get out today is go get screened, go find out if you're pre-diabetic so you don't have those complications in the end.
Yeah, just to clarify, CHECK, so that's the Community Health something center, education center. I can't remember what it stands for, but it's in the basement of the same building that we're talking about on the Midtown campus, where our clinic is and everything. So in the basement, you can go and you can get screened, not just for diabetes, but a bunch of other stuff as well. So it's a really nice community service that we have, on our campus, so people can come in and get checked out. What's my blood pressure? What's my sugar? What's, a lot of other things as well.
So when they want to come there, though, should they, make an appointment before they come, or how does that process go? If they want to come and just to get a checkup really quick.
Walk-ups are welcome. They can
okay.
Just come. Yep.
Okay, because it might be out to listen. I just had a time at this restaurant on the street. I just want to get checked up real quick. Sometimes it might be a pop in like that.
Yeah, that's what it's meant for. It's really meant for people just to come in and get checked out. Like you said, maybe they listen to this and they're like, you know what? I haven't had a blood test in a long time. Let me go at least get checked out. So it's a quick and easy way.
We love that. And then, continuing the conversation, Dr. Moran, about, what you can eat and what you can't eat, or maybe what you should stay away from. I know you spoke a little bit about the sugar, but earlier I Googled the most asked questions about diabetes. And for some reason, everybody wants to know, can you drink alcohol if you have diabetes? Now, I don't know why, from the sugar to the alcohol, those were the two top questions. Let's talk about that.
About alcohol?
Alcohol and sugar, which really is the same thing, because a lot of alcohol has sugar in it regardless.
Well, yeah.
But
I mean, there's so many studies about basically saying stay away from alcohol. But if you are going to drink, which, again, we're not prohibiting anything. We just want you to stay your glucose in check, right? If you are going to choose an alcoholic drink, try to choose one that doesn't have sugar, or at least that has low content of sugar. So what do I mean? Instead of a pina colada with, dark rum, maybe go for vodka and spritzer, or, one of those, what are they? I don't remember the brands, but the ones that have like basically no calories. So I think if you're going to do it, choose wisely. And when we're talking about sugars, I think one of the things that it's just staying away from processed sugar. Processed sugar and fats really are just going to, disrupt your whole metabolism and your whole goal, which is really to keep those carbs dressed, for lack of a better word. We want to pair always those carbs with some fiber and protein. So instead of, for example, when you're having breakfast, right, instead of having that coffee with the donut or a piece of bread, right, you might want to switch that to an avocado toast, right? It has a little bit of fat, maybe has an egg and that fiber. So you always want to make sure that the carb is not eaten by itself, that the sugar is not processed sugar like a cupcake, right? Or a piece of candy, right? I'd rather you have some fruit, an apple, right? Something that has more content of fiber that is not, again, we're going to try to stay away from those spikes.
Okay. All right. So good. So I think tonight, really, this conversation was so important because a lot of people can take away these things. Hopefully, you're jotting down some notes. I'm taking mental notes because the weekend is upon us. So I want to make sure, and my birthday is May 5th, Cinco de Mayo. So I want to make sure that as I'm leading into a new year of life, I'm doing a lot better. So this is perfect. I posted in my listener chat. I have like a chat where I ask just a couple questions you might have about live events I do. The first question they ask is, if you're overweight, will you always develop type 2 diabetes? This is the question that somebody wanted to know. Dr. Chow, do you want to chime in on that question?
No, that doesn't mean that you are definitely going to develop diabetes, but you're at increased risk for developing diabetes, and you should definitely get tested. Mm-hmm. That's the message here. Everyone should just get tested. And if you're overweight, you're at increased risk, as Dr. Morán mentioned, and so get yourself tested. The good news is that if you test and you end up being labeled as being pre-diabetes, that losing that weight can improve your hemoglobin A1C, and then suddenly you can slip out of that pre-diabetes category and back into what would be the normal range. So it's something that can be treated without medication.
And for those people who are just chiming in, also, Glenetta says, are there any concerns about the sugar content in fruits? I eat grapes daily. I always heard that like red grapes are better than green grapes. Like, so is there any difference?
I want to say something. It's like, first, I am not a nutritionist. That is a whole specialty. So I am not going to, I'm going to stay in my lane. But fruit definitely it's a readily available sugar than if you would eat anything else that had a sugar content. And by the way, a lot of stuff has sugar content. The tomato is going to have sugar content, right? But if you're eating something that is more sweet, that just means that it's higher in the quantity. So one of the things that we teach in the diabetes prevention program is how much you have of fruit, for example, that you have to eat, right? And again, always trying to stay away, and portion control, which is one of the big things, right? When we're talking about, for example, grapes, you don't want to serve yourself the plate with the whole thing of grapes, right? You want to measure out maybe a quarter cup and just stick to that, because then it's just easy to keep eating while you're watching TV, while you're doing something else. And then you don't really realize how much sugar you're eating. So make sure, first of all, again, the nutrition is the whole specialty. I don't want to get into that, but just portion control when it comes to sugars.
Yeah, I agree. Definitely portion control, because I'll eat the whole bag. What were you going to say, Dr. Munir?
No, I think that's an important point, because I think people will eat sugar-free or low-sugar snacks. And the sugar-free, sometimes they have something called sugar alcohol, which do have some ability to raise your blood sugar. And so they'll just eat more of it. So if you're eating half, but you eat double, then you end up eating the same amount that you would have eaten anyway. So, and then fruits are interesting because they have natural sugars, usually fructose. Some fruits tend to be less problematic, like berries tend to be less problematic for your blood sugar. So like blueberries or blackberries or strawberries, things like that. And other fruits are sweeter, like green grapes and so on. But what's really interesting also is that there's a lot of individual variation. And so somebody could eat a banana and their sugar might spike to 300, and somebody else could eat that same banana and they might not even see a rise at all. So if you have diabetes, it's always, and these sensors actually help us now, because you can see what happens with different foods, and you'll know which foods are your trigger, which really causes sugar to go up, and which foods you can kind of get away with more. And like Dr. Morán was saying, that even the ones that cause your sugar to go up, you just eat less of them, right? So we just portion control things that affect us more. So I think diabetes and nutrition therapy used to be very list oriented. This is the stuff you can eat. This is the stuff you can't eat. And all the stuff in the can't eat pile was the stuff that you love. So people would do it for a week or two and they'd be like, oh, this is crazy. I can't do it anymore. So now we try to teach people more about what are these different foods, what's the carbohydrate, fat, protein, and then the stuff that may be a little bit more concerning for your blood sugar. We just work on portion control for that. So there's almost nothing that's on the cannot eat list. Certain things are just like have no value whatsoever, like soda. So there's no nutritional value. It's just pure sugar. So there's try to get people not to do that kind of stuff. But most foods, there you can still some. It's just trying to figure out portion control on that.
And I want to take it back a little bit to the beginning of the conversation. I know we touched on this just a little bit. Dr. Chow, can you talk about, is this true that more people are being diagnosed with diabetes at a younger age? I know we talked about the age factors a little bit earlier.
Yes. That's, and I don't know why. I'm sure there's some social, there's a phenomenon among children these days, but I think children, maybe they're not as active as they were. Maybe that the diet is different than what it was, but the children, that the sedentary lifestyle is a risk factor for developing diabetes. Obesity is a risk factor for developing diabetes, and unfortunately, we see a lot of childhood obesity, much more so than in the past. And not only are children developing pre-diabetes and diabetes, they're also developing hypertension at an earlier age than in the past, and high cholesterol levels compared to what it's been in the past. It's concerning, and it's something that from a population health standpoint, we need to be more active about trying to address. Are you all seen that, Dr. Morán, Dr. Munir?
Yeah, no, it's definitely happening. I think that's, like we said earlier, it's one of the reasons they changed the name, because juvenile onset, it was like if you're a kid and you get diabetes, it's almost always type 1. And now we see teenagers with type 2. And so, there's a lot of things like Dr. Chow was mentioning. It's just in terms of social and even kind of governmental policies, right? They've they do things like they subsidize corn, which is cheap, and so then you can make food out of corn, which is not really a healthy component to a lot of foods, like high fructose corn syrup and stuff. And then there's just easy access to calories now, and fast food and things like that. It's just so easy. It's cheaper. It's you're on your way home, you just stop off, you get this stuff, and you eat it, and it makes you feel good. They kind of make it addictive on purpose, and they advertise it like crazy. So it's hard to avoid. It's really a challenge. So I really feel for everyone, because it's a tough thing. But I think we've gotten away. I had one of my old professors who used to, when they would go on vacation and they would drive by McDonald's, his kids would say, "Oh, daddy, McDonald's, we want to eat there. We're hungry." And he would just turn around and say to them, "It's okay to be hungry." And then he would just drive on. And so, I think we've forgotten, it's okay to be hungry sometimes, that we always want satisfaction, instant gratification. I mean, it's kind of like the way the world is going, but it does make a difference, right? And so sometimes being hungry is okay, and you don't have to always satisfy that right away or immediately with high caloric dense food.
Yeah, what Dr. Munir is saying, it's so true, though. I remember when I was growing up, if I wanted something from the store, I would take my bike and go to the store and then come back, right? Now you have delivery apps, and I see my stepdaughter, she'll order all day, ice cream, McDonald's, this and that, and it just comes to the door, right? So it's just, the world is changing, and we just have to, I think, create more awareness of those changes and how they affect the kids and young adults and the population in general. We were talking about COVID earlier and how we left that pandemic, right? But diabetes has been an endemic in the United States since 1997, I think. So, keeping that in mind, that the prevalence has always been there, and instead of going down, it keeps going up.
Yeah, and I think also what all of you are saying, and definitely Dr. Chow, earlier you talked about how kids just aren't as active as they used to be. A lot of kids are on technology. They want the fast food. Dr. Moran, they're getting food delivered to the door. They go right back upstairs and they're playing video games. What would you say are some like simple like lifestyle modifications that we can do to help prevent diabetes? Of course, to be more active, to watch your sugar intake. What are some different things you would say, Dr. Moran?
I think you have to be purposeful about making conscious decisions. So it's easy to say, all right, I'll be more active, but how are you going to be more active? What activities are you going to do? How are you going to include that throughout the day? And all it takes is 150 minutes a week. That's 30 minutes Monday through Friday. It's not that much, but only that makes a huge impact. So how are you going to include those exercises? If you're in an office all day, make sure you take a 10-minute break 3 times a day and go walk around the block, right? So being intentional of how you're including those activity minutes, and being intentional on the food, the diet that you have, how you're going to eat. And again, it's not black and white. You're not going to stay away completely from sugars and carbs, but it's about moderation. How much do you eat? And making sure that first you include that salad, that fiber, those vegetables, and really be conscious about increasing that within, throughout the diet.
And I think what Dr. Moran said is really important actually to focus on is that exercise doesn't have to be, you need a gym membership and you have to go for an hour and and you have to do that every day. Like it can be in chunks. And so we call these exercise snacks. So you have a little snack here and there. You do 5 or 10 minutes of exercise, a quick exercise snack, right? And what they've also shown is that, especially for kids, but even in adults, that you have to limit your constant sedentary time. So if you're sitting for 3 or 4 hours, and they've done experiments on this, you're at much higher risk metabolically than if you break it up every half an hour, just take a 2 or 3 minute walk, right? So just breaking up that kind of complete sedentary time. So exercise, we pay a lot of money now to just expend energy. It's like you can do that for free if you really need, you don't have to do that. So I know for some people it's an issue to find safe spaces to exercise. So I do recognize those are limitations, they're real limitations. But even in the house, there's a lot of videos, there's things you can do, just to kind of keep active. And so it doesn't have to be something very exquisite or fancy and going to this gym with this $1 million equipment. It can be done at home, and there's a lot of things that you can do even within the house or in your neighborhood, if that's a safe place for you to exercise.
And I want to add to that because I thought it was so great what you're saying about there's the limitation of not being able to go outside sometimes because it's not safe, because you don't have a park nearby, whatever it is. There's so much information and so many YouTube videos about how to exercise at home without any weights, and if you have a lesion in your knee or whatever, there's exercise you can do sitting down. So there's really just everything that you can choose from online. So just being intentional about exercising and making sure that you avoid all of these risks that we've been talking about.
So even though you criticize Google can be helpful sometimes.
We did have a question I want to pop back. There we go. Once you've been diagnosed with diabetes, we have this disease for the rest of your life, even if you take control of your health. I think that's a good question. People probably want to know, is this going to be stuck with them forever? Dr. Chow, do you want to hop in on that?
Well, it's hard, but you can be cured. You can be, and I've had patients with diabetes, and they underwent a gastric bypass procedure, lost a significant amount of weight, and I just started taking away their diabetes medicine, because they didn't need it, and soon they were not on any diabetes medicine at all, and they were doing fine. and all of a, it's like the diabetes just went away, just melted away. That was and for those patients, it was very rewarding for them to feel like they were able to manage their diabetes in that way. So the answer is that you don't necessarily have to. It's not a life sentence, and also that you're not you're not attached to these whatever medication you're on. That also is not a life sentence. That these medications can be weaned off, can be changed, it can be restructured. It's a dynamic process. Is that your experience, Dr. Morán, Dr. Munir?
Yeah, I agree with you. It's not a sentence for the rest of your life. However, if you have been diagnosed with diabetes, you should always keep an eye on it and just make sure that you're checking your A1C, because the diagnosis doesn't go away. Literally, like, you're still a diabetic patient, I guess, for lack of a better word. Like, your pancreas struggled, so you should always check. Yes, definitely, it's not a life sentence, and you can get away from the medicine and you can have it completely under control. But you always want to be checking that. You always want to make sure that every 3 months you get your A1C.
Yeah, I mean, so I would agree with that. I think we don't use the word cure because I think what Dr. Morán is suggesting is that once you've had it, there's a risk there. It's like what she was saying, if you're pregnancy and you've had diabetes, what we call gestational diabetes, you could go back to having normal sugars afterwards, but there's always that risk underlying. So they use different terms now, like in remission or post-diabetes sometimes. So they have these things that people who are on medicines or treated can actually get off of everything. And so I think that's a great point Dr. Chow made. Even people on insulin can get off insulin. So people sometimes have this thought that once I'm on insulin, I'll always be on insulin, but that's not true. If you make significant changes, and we've had patients who've had A1C level double digits, 10, 13, 14, like those are really high. Those equate to like an average sugar of 300-400. And within 6 months to a year, they really work hard on their diet, exercise, lose weight, and they're off of everything, and their A1C is 6. And so that happens even without surgery, even just with good old-fashioned hard work. So it can happen, and we have people that are very motivated when we do that. So I think it's a great motivation that we always prefer. If you can treat something without medicine, that's always the best. Now, some things you can't, or sometimes you can't, but if you can, that's what we're all for.
And I hope that this conversation, as you were watching, you had some great takeaways. I mean, I think I've learned so many tips on how to prevent diabetes as well as manage diabetes from children to adults. There's so many different options for you. Thank you so much to all of our experts tonight. Can we give some resources before we go for those who might have missed some resources early, and also for those who missed that you can just walk into the facility and get checked out right away? Dr. Munir, I want to start with you, and then we can work our way down to the bottom.
Yeah, so I think we're always here as a resource at our diabetes center, and then we have, like you were mentioning, the community health education center, which is called InCheck on our campus. Online, there's actually all kidding aside, Google or there are a lot of good sites as well. So it's like everything else, there's good and bad. But the American Diabetes Association, or ADA, they have a lot of great information online for patients. There's the CDC, which is has a lot of information about prediabetes and their diabetes prevention program. And there's a lot of reputable sites out there like that. The Endocrine Society, and there's something called the American Association of Clinical Endocrinology. So all of those have a lot of great patient resources, a lot of information. And I think they're great tools for people to use right from their house. They can look them up and see how they can make their life better.
Thank you so much, Dr. Morán.
Yes, just a reminder that we have our check where you can get tested, and to join the programs, either DPP or DCMT, and you can find out more at umdiabetes.org.
Thank you so much, Dr. Chow.
Hey, so I practice primary care at the Midtown Health Center. which is in the same building as the diabetes center that Dr. Munir and Dr. Morán practice in, and we welcome any and all patients and love to try to help you out if we can.
So make sure you go see our experts. Hopefully you gained a whole lot of information. Tonight was all about tools to prevent and manage diabetes, presented by University of Maryland Medical Center. Have a phenomenal night. Treat your body good, and your body will treat you amazing. Thank you so much, doctors. Appreciate you.
Thank you.
Have a good night.